distinguished senior physicians, dear colleagues, a very good warm welcome and good evening to all of you. We had two very interesting sessions lined up for this evening. The first session is titled Spectrum of Insulinization from Hospital Admission to Post-Discharge, and this will be followed by a case presentation titled Unnoting Noti Muscles. So let's begin with the first session of the evening. We have Dr. Subramanian Meena Karthik, or rather Dr. Karthik from Silverline Hospital. He is an endocrinologist in both adult and pediatric age group. And the session will be chaired by Dr. Ramakrishnan. May I invite Dr. Ramakrishnan and Dr. Karthik to kindly occupy the dais, please. Now, as for the chairperson, Dr. Ramakrishnan, I had the pleasure to introduce him. Well, he has been a well-known figure among the physician community of Kochi. He was the past president of IMA Kochi. He has been the founder secretary of IMA Blood Bank. He has been the editor of Kerala Medical Journal. He was the secretary of RSDI Kerala and chairperson of API Kochi sometime back. And he is the faculty for certificate course on diabetes conducted by the Public Health Foundation of India, which is a government of India undertaking. But apart from that, he has got an extraordinary career in sports, which very few of us can boast of. He has represented Kerala University in all major 3 games. That's football, cricket and hockey. Wonderful, sir. And he has been the Kerala player in both hockey and cricket. And perhaps we should all know that he is the only sports person from Kerala University who has scored a century in inter-university tournament. So that's something extraordinary among all physicians. So may I request you to take over the session, please.
Good evening, colleagues. The World Diabetes Day has already passed by as usual, and it is apt that a topic on diabetics has been taken up by the API for today's meeting. You know that more than 60% of the patients admitted in hospital are diabetics. From your experience, you know that, or on OHAs. And now various procedures are being done in different hospitals: cardiovascular surgery, neurosurgery, brain transplantation, all these things. In all these cases, we may require insulinization. So insulin plays an important part in hospitalized patients. You know that insulin is the only drug, probably the only drug, which had stood the test of time, more than 100 years, although it has now donning many garbs, t-shirts and all these things, shorts and other things, still it becomes an integral part of treatment as far as diabetes is concerned. But very importantly, I would like to emphasize what Jocelyn in 1923 has said about insulin. We all use insulin. But what he has said is, insulin is a remedy primarily for wise and not for foolish, whether they be doctors or patients. This is the most important statement he had made in 1923. Again, he goes on to say that everyone knows it requires brains to live with diabetes, but to use insulin successfully requires more than brains. So that is the most important message we have to imbibe when we talk about insulinization. And to talk about all these things, we have with us a young endocrinologist from Tripunithura, Dr. Karthik Subramanian. To give a brief review of what he is, because he may be quite new to all of us, he is a consultant pediatric and adult endocrinologist, Silverline Hospital, Kochi, MBBS in Government Kilpak Medical College, 2014, 4 and 10 in Chennai, MD General Medicine from Government Kilpak Medical College, Roypata Hospital, Chennai, DM Endocrinology from Sanjay Gandhi Institute, Lucknow. That's a very prestigious institute as far as endocrinology is concerned. Achievements: paper presented at Indian Institute of science during the first MBBS. So he started his career from first MBBS onwards, this academic career. Gold medalist in anatomy, biochemistry, pharmacology, and second in certificate in pathology. Best outgoing student in 2004 batch MBBS. Won Niyamatullah essay competition organized by Indian Society of Nephrology, Southern Chapter in 2012. Underwent intensive training program in diabetes for secondary care doctors in CMCH Vellore. Won the poster presentation during ISICON 2017. 2 posters presented in ISPAD in 2018 conference. 2 research articles in gynecological endocrinology, fertility and sterility, and 2 case reports, Journal of Postgraduate Medicine as first author published. Reviewer in few journals, Endocrine Connections, JPGM, member of the Endocrine Society of India. So it's a beautiful resume of his academic brilliance, and it's my proud pleasure to give Dr. Karthik to you to speak about the spectrum of insulin usage in a hospitalized patient at the time of admission as well as at the time of discharge. Because at the time of discharge is very important for you to prescribe the right dose of insulin, the right insulin at the right time. Over to you, Dr. Karthik.
Yeah. At the outset, good evening everyone, dear senior colleagues and my dear friends. I would also like to thank sir for his kind words. Probably this was a resume which I just typed in while I was searching for placements, so that's why it is a bit fancy, but yeah, proceeding on. Now you could just see that with your permission or without your permission, I just changed the topic from spectrum of insulinization from outpatient to inpatient scenario. Why? Because I'm pretty sure that you have quite a lot of physicians have experience much more than my age in managing inpatient and outpatient glycemic problems in type 2, type 1 diabetic patients. So with respect to critical care management, I'm not going to just dwell into very much because it's up to the critical care society guidelines and insulin infusion guidelines, so which is beyond the scope of today's discussion. Since as has been displayed also, it is primarily there is a financial disclosure, and this has been sponsored by Novo Nordisk. I am primarily going to base my talk on general concepts with respect to diabetes in COVID and how to manage it in inpatient non-critical illness of COVID and while discharge and on outpatient basis, with specific emphasis on a co-formulation. This is not new to everyone that for appropriate management of COVID patients, be it inpatient or outpatient or generally even in the preventive aspects, it is important for appropriate management of diabetes. That is what all the societies throughout the world emphasize upon. So what is it with respect to diabetes that we are concerned, or why are we very much sort of concerned regarding hyperglycemia, especially in patients with type 2 diabetes? We very well know, that is, everyone knows that diabetes is a predisposing factor and a very high risk factor for quite a lot of surface fungal infections, quite a lot of chronic granulomatous infections. And why? It's because of its main sort of pathophysiological mechanism in inhibiting the functions of neutrophils, natural killer cells, monocytes, chronotrophs, and also other in vitro studies emphasizing the role of ACE receptors in the pathophysiology of COVID, that this predisposes, one, to increased infections, two, it predisposes to critical illness, three, and it is also a risk factor for morbidity and mortality. On the right side, you could also see the reverse causation, that is COVID now is an established risk factor for new onset diabetes, probably also type 1 diabetes, because there has been several case reports and probably case series for autoimmune causation of diabetes after COVID infection, not necessarily severe illness but also moderate illness. So it not only causes beta cell damage but also causes autoimmune diabetes through its mechanism in influencing the immunity. So as an implication, what happens is people with pre-existing diabetes have higher risk of severe disease of COVID or death in COVID, and that is what I was just emphasizing in the previous slide. So why is this important is because we will have to manage diabetes in an appropriate manner even before the onset of COVID. This acts like a risk factor reduction. So over your left, you could very well see in the upper left of the graph, there is a linear association with pre-infection HbA1c with severity of COVID illness. And over your right, you could see the relative risk gradually increasing with higher levels of HbA1c. And on the right part of the slide, again you could see the implication, that is the mechanism in which it is going to be protective. That is, always we know that it's not just a linear association that is going to help us, but is also intervention part which is going to be which has to be proven. So by reducing glycemia, whether it is reducing the relative risk, yes is the answer. So of the agents, we know there are quite a lot of agents for treatment of type 2 diabetes especially, and of the agents, it is not a rocket science that everyone knows that insulin is one of the best agents that reduces glycemia in a very effective, sustainable manner. And of the agents in insulin also, it is seen that premixed insulin, just because of its simplicity, the mechanism of 24 hours action, it plays an important role in effectively reducing to a much greater extent the glycemia. Before going on to next further slides, I would like to spend some time with this slide, because this is one thing which I carry every time with all insulin presentations. Over your left, you could see two pie charts, and over your right, a graph. So this is a table. Over your left is an interesting and important study that has probably that had taken place in Scandinavia almost 2 to 3 years early. The A pie chart is the routine clinical diagnosis of diabetes. 93% were so-called type 2 diabetes, 5% were so-called type 1 diabetes, 1 to 2% were so-called secondary diabetes, probably hormone related, pancreas related, pancreatitis related, so on and so forth. But over B, you could see almost 5 subtypes. These subtypes were based nothing but based on clinical parameters like BMI, presentation HbA1c, GAD antibodies, C-peptide levels, and the that's what the BMI, these 4 parameters. So based on this, they classified into 5 categories. The 6.4% which shows is severe autoimmune diabetes, that is classically what we call as type 1 diabetes. So based on this clinical classification, you could see almost 5.2 and 6.4 coincides. But there is another percentage, that is 17.5%, which is also severe insulin deficiency, but it is not autoimmune. So this is one thing which I would like to emphasize, that is in almost 1 in 4 patients whom you see in routine OPD, just based on clinical parameters, you could diagnose them to have insulin deficiency. So 1 in 4 patients requires insulin on outpatient basis because he or she is insulin deficient. This 15.3% is what is called severe insulin resistance. They were obese, they had high C-peptide levels. 21.6% were what is called as MOD, that is obese diabetes. They had very high BMI and C-peptide levels were normal. this 40 percentage, 39.1 percentage is called MARD, mild age related diabetes, age more than 60 while they had diabetes with normal BMI and normal C-peptide levels. So just to take home, in Scandinavia up to 25 percentage were having severe insulin deficiency, of which 6 were autoimmune and 17 were non-autoimmune. Over your right is the Indian study. The same cluster classifications were tried upon in Indian study published by Vishwanathan et al. So you could say almost a good number, almost 20,000 patients were categorized. And again here the cluster 1, SIDD, severe insulin deficiency diabetes, you could see the frequency is 26 percentage. This is what I was just trying to emphasize upon. 1 in 4 person even in India were severely insulin deficient. This is diabetes onset more than 40 years of age. So in an otherwise so-called adult onset diabetes, you could see 1 in 4 are insulin deficient. So this is what I would like to just emphasize, and this is what I would like to you everyone to sort of understand as a take-home message, that quite a lot of people are insulin deficient and might require insulin in day-to-day practice and outpatient basis. So this is one probable physiology or ex vivo study or ex vivo evidence showing probably insulin might be acting as a protective agent, but of course it's not proven in vitro, in vivo. So probable mechanism stated was increase in pH by increasing the amount of hydrogen in the cell as insulin stimulates the exchanger, sodium hydrogen exchanger. So in Indian scenario, which insulin seems to be more appropriate, because we have characteristics of high carb diet which everyone is aware of, and it is very difficult to ward it off also, as a result of which there is higher postprandial glycemic levels, and typically patients are reluctant to start on insulin even if they require, and they are on multiple or probably 5 to 6 oral agents by the time they reach you, and they also are hesitant to use insulin. So what happens with respect to COVID, that is while during pandemic and during lockdowns, as we anticipate, it is more of postprandial glycemia that is affected, definitely because of quite a lot of reasons, availability of food, lack of exercise, so on and so forth. So that is what is again an important problem during lockdown times. So in this scenario and in COVID times, definitely the typical recommendation of starting basal insulin in an otherwise uncontrolled type 2 diabetic individual is definitely not going to solve any of these four problems. So this is why there is an emphasis on using either pre-mixed insulins or co-formulations. That is, we need to use both rapid and long-acting insulin. And one specific mention with this co-formulation is that this is a combination of, as everyone knows, aspart and deglutec, and this is called co-formulation and not an typically not as a pre-mixed insulin. Why? Even that everyone knows, because pre-mixed insulins are like a proterminated form of already present insulin, but this is two completely different insulins that are mixed into a single cartridge. So aspart is present as hexamer and deglutec as dihexamer. What happens on subcutaneous injection is that since zinc and phenol diffuses rapidly, the aspart hexamers dissolves immediately without affecting the pharmacokinetics of deglutec, and deglutec hexamers forms long chains of dihexamers, as a result of which it results in sustained and gradual release of deglutec. So the pharmacokinetics of both of them are not altered in this co-formulation. This is what is represented in this slide, which you could just see, and it's everyone knows also. Another important or most important aspect is its efficacy in comorbidities. Most important is renal impairment and hepatic impairment. You could see throughout the spectrum of renal impairment degrees, that is until ESRD, and throughout the child book scores, almost the lines are overlapping. So there is no great difference between the deglutec component of IDEG-ASP across the spectrum of comorbidities, but the aspart component, you could see there is a mild change in the peak with mild, moderate and severe renal impairment, not to that extent in hepatic impairment. So this is definitely safe to be used and almost in the similar dose or just with a mild dose modification in renal impairment, and not to such an extent, or not to be worried about to such an extent in hepatic impairment. And this IDEG-ASP has been tried and tested, and with all combinations, insulin naive, insulin already using insulin patients, premixed changed over to IDEG-ASP, GLP-1, SGLT2, so on and so forth. And across the spectrum in 3A, 3B studies, it has been proven, 1, to be efficacious, 2, to be safe, especially reduce the incidences of hypoglycemia, 3, reduce the incidence of asymptomatic hypoglycemia, 4, to reduce the incidence of asymptomatic nocturnal hypoglycemia. So this is one such study comparing with glargine 100. And I am sure everyone is aware that glargine 300 is considered second generation basal insulin, and it is like on par with insulin deglutec. So this is in comparison with glargine 100 units. You could see almost efficacious or to a certain extent a bit better glycemic control with HbA1c. And over your right, you could see the fasting sugars are almost similar with both insulin titrations. So IDEG-ASP was given at night predominantly in this trial, and glargine also was given at night in this trial. So they, to a same extent, they had reduced the fasting hyperglycemia. But one important and significant difference, even in spite of giving IDEG-ASP at night, is reduced incidence of confirmed hypoglycemias and also nocturnal hypoglycemias. So this is one thing that happens even in spite of rapid acting component present in co-formulation. That is, aspart component present in co-formulation, even in spite of that, there is reduced nocturnal hypoglycemia. So this is one important intrinsic property of deglutec insulin, which you will have to remember and we will have to emphasize upon. As a result of which, our Indian RSSDA guidelines have recommended that this could be a choice of initial insulin initiation in people who are mandating that because of various reasons, be it glycemic poor glycemic control, or due to several of the reasons, this could be very well used as an initial insulin in the place of basal insulin. So another important sort of benefit or advantage which we have is that, one, in those who are already wanting basal insulin, we could initiate that. Second, this could also be very well titrated to cover 24 hours glycemic control. So most important category, I think I would like to get your experience also, which I use to switch over to this IDEG-ASP, is those who are on uncontrolled glycemia with premixed insulins. In that category, definitely this premixed, this co-formulation scores very well, or in fact very better than other insulins. And of course, in people who are uncontrolled with OAD, as has been emphasized before, we could very well start with this. In people with basal bolus, it is a bit difficult because this is a co-formulation, but patients uncontrolled on basal insulin, definitely yes. So first three categories, definitely yes, and more in what I see is converting from pre-existing premixed insulins in which they are uncontrolled to this co-formulation. Of course, because of its risk factor reduction, that is hypoglycemia reduction, this is very safe in elderly, in people with comorbidities, especially hepatic and renal impairment. So just few scenarios: an person with multiple OADs, uncontrolled, obese, fasting 210, postprandial 300, with otherwise sedentary lifestyle, hypertensive, smoker, and on quite a lot of agents, and also SGLT2 inhibitors. in such a scenario, it is always, that's what, as we had, there are quite a lot of options available based on the cost and preference of patients. In this current era, even GLP-1 analogs could also be used. Yes, use in such an individual who is already obese would be out of question. So among insulins, we have an option of basal alone and co-formulation. So if we choose co-formulation, we could very well start with low dose, gradually up titrate. There are quite a lot of apps that are helpful these days to titrate insulins also. And typically the dose titration is done after almost 3 to 4 days. Why? Because this is very long acting insulin, so this requires some time for the steady state to achieve. So in such a scenario, you could see gradually in this hypothetical case the glycemia getting controlled. This is one of the scenarios which everyone encounters. And yeah, in persons or in people who are admitted in hospital for hyperglycemia with or without steroid administration, with or without clinical illness, definitely we are bound to use IV insulin regime. That is what I was just emphasizing before, which is out of scope of discussion today. But while such patients are sort of step down to step down ICUs, or when they are transferred to wards, based on the total daily dose and based on the basal bolus insulin regime, we could very well convert them into premixed insulins by the time of discharge. That is what is the sort of message which we want to emphasize with this second scenario. I'll just be coming on to the titration or the dose titration or sort of dose exchange, which we will be looking at, or which we would be wanting the patients to take on discharge. So one of the impediments to achieve good glycemic control is, over your left you could see the qualitative research stating that insulin regime is not very adaptable, that is, it is very rigid. So that is one thing again which could be changed with this co-formulation because of its long action, and it could be taken with the largest meal in a day, anytime a day, because the basal component is going to act for 36 hours. And generally over your right you could see, higher the risk of hypoglycemia, higher the hypoglycemia, higher will be the fear of hypoglycemia also for the second or third time. So this is one important less emphasized aspect, that hypoglycemia is a very important risk factor, or it impairs the quality of life very severely, and also it is a procoagulant and an arrhythmogenic risk factor. So it's a simple logic that while we are changing from basal bolus to co-formulation, the number of injections reduces. And this is one comparison with basal co-formulation with basal bolus regime. You could see by equal dose conversion you could very well reduce the incidence of hypoglycemia. Again, over your left lower graph you could see substantial reduction in nocturnal hypos, asymptomatic hypos over a duration of 26 to 38 weeks. So this is what I was just alluding to. While we are concerned regarding changing from already existing basal insulin or already existing premixed insulins to IDAG-ASP, it is suggested to be changed unit to unit wise. But I would also like to get everyone's sort of view in this. Generally I reduce by at least 20%, and I see that works well. And while the person is already on more than twice a day premixed insulin, again it is suggested to be used on dose to dose basis, and if it is basal bolus, highly individualized, because we need to use another bolus in between. Generally speaking, because the long acting component is very long acting, it is generally advised, or my personal preference is to reduce dose a bit. So without taking much of your time, I would like to summarize by saying that everyone knows, I'm just re-emphasizing the fact that it is an COVID, in the present era of COVID, diabetes is an important risk factor for severe illness, morbidity, and also mortality. And we'll have to remember 1 in 4 patients who are presenting to OPD would be insulin deficient in an otherwise adult so-called type 2 diabetes. So insulin is always there as an option, and we must not deny them or postpone insulin in them, and easily clinically characterizing them is pretty easy. And of the formulations or premixed formulations present, co-formulation gives us the better opportunity to reduce nocturnal hypoglycemia and also asymptomatic hypoglycemia. And dose switching is one thing where we will have to be a bit careful, because while switching in the presence of a bit higher doses, they might develop hypoglycemia, so it's always advisable to reduce dose a bit. Thank you for your patience.
Hello, very illuminating talk. The case, the discussions open. Few good, intelligent questions to Karthik. What is your experience with this molecule in your day-to-day practice? That's the most important thing. Basically, I have started using this ever since it came, because I was fascinated by that longest acting as well as short acting. And in most of the patients, I have felt that one single dose along with some OHS will be more compatible. Patients will be more accepting one dose rather than 3 dose, basal bolus and other things. So I have started using this in many of the patients, and patients are very happy, except for the price. But if you can explain to the patient the difference, if you take a mixed TAD or any other things, increasing the dose, you can reduce that also. So my personal impression about this drug is very good. Any more comments, experiences? Let me ask one question, Karthik, since no one is. You have always said that use it with the largest meal. So when you talk about the lifestyles of Keralites, most of them, I think I am told that dinner is heavy rather than breakfast. A frugal breakfast, a little bit more lunch because of the activities, and most of them have a very good dinner. So would you say that it will be appropriate for them to use it at night? Because major meal means, and especially our diets are carbohydrate rich diets.
Thank you, sir, for your important question. Definitely, yes. As you have been saying, predominantly quite a lot of people take a major meal at night, and surprisingly, in quite a lot of studies also, even RCTs, you could see that it's the dinner which is a major meal. So it's not confined to India. We can be happy with that. So it is quite common elsewhere in the world also. And yes, because the long-acting component is going to remain the same. It's the short-acting component for which we are wanting it to be taken along with the largest meal. I think definitely yes. Quite a lot of my patients also take it at night, and I don't probably. It might be a fact that we are monitoring less, but nocturnal hypoglycemia is one important thing which I have been emphasizing quite a lot of time. Probably we are monitoring less, but even in spite of that, nocturnal hypoglycemia seems to be low with such co-formulation, even if we use it at night, which has a rapid acting component.
What about Shyamla? You have got a lot of experience. Not much. You are not using it. Raju? No. Dr. Ajay? Yeah, yes, they can always participate. What should I do for that? Yes, yes, those who are watching this online can definitely ask the questions. We will answer your questions. Don't hesitate. Please, please. It's a very interesting molecule. Most of us can use.
Right, sir. So,
Yeah.
yeah. Hello, sir. Can you please use a single device? Hello, are we audible? Hello, sir. Dr. Gopalakrishnan, sir.
Sir, you have said there is a group of persons who are deficient in insulin. That is why degludec ask is good. How to find out that there is an insulin deficiency in these patients?
Okay, sir. I get your question. So, insulin deficiency, according to the, even my voice is getting echoed. So, according to the study which I had shown, that is a clinical phenotype study, they had used C peptide levels, a fasting C peptide levels. So, fasting C peptide levels of less than 0.6 nanograms per ml is taken as absolute insulin deficiency. That is for the sake of study, but that also applies clinically also. So generally when a patient comes to you randomly, even with or without medications or with or without insulin also, you could just take a random fasting C-peptide levels and correlate with the fasting sugars. There is another index called C-peptide to sugar, that is a glucose index. So C-peptide must be in picomoles. It's a simple conversion which you could use, divided by sugar as such in milligram per deciliter. The number, if the ratio comes less than 2, it means that there is severe insulin deficiency, and if the ratio comes more than 6, it is they have adequate amount of beta cell functioning. So again I would just like to repeat, C-peptide in picomoles per liter by glucose in milligram per deciliter, the number less than 2 deficiency, greater than 6 sufficiency. But in the study what they had used is the definition of 0.6 nanogram per ml. So by this way we could very well sort of so-called diagnose insulin deficiency, and this typically works if person is diabetic for at least more than 3 years. Why? Because initially even type 1 diabetics would have adequate amount of beta cell function, so this won't be helpful in categorizing people in early stages of diabetes. So at least 3 years down the lane, definitely this is going to help us to identify beta cell deficiency. I think I answered you, sir. Coming on to sir's question.
I was just pointing out, since degludec is such a long-acting insulin, quite often we find people prescribing twice a day. Now we see people prescribing it twice a day. It's generally required. Instead of prescribing twice a day, we can give an additional dose of short-acting aspart, isn't it? Instead of degludec twice a day.
Sir, actually that is the problem which we have with all mixed insulins. Now, for example, a person has a fasting sugar of 250 and post-meal sugars of 350. You are starting once a day, probably 16 units, and his fasting sugars gets controlled. It comes to probably 120, and after meal becomes 180. So you are satisfied, the purpose is solved. But in the same scenario, when you are using once a day degludec, it's of 16 units, fasting sugars is still 200, after meal sugars becomes 250. So in that case, you could use second dose, you could use it as BD. Why? Because increasing at the same time, that is instead of 16, if you want to hike it up to 24 or 26, you will land up in postprandial hypoglycemia. So there we need to space it to other part of the day, probably second greatest meal which he takes. Probably it might be in, if the first dose is in the night, probably second dose might be in afternoon or morning. So this is the second scenario. Third scenario is where, well, you are using the same co-formulation of the patient, 200, 250 and 350. The fasting becomes fine, 120, but postprandial is still high, in the sense again 250. Though after using 16 units of IDEC-ASP, fasting is 120, after food is 250. Here again, you would want to use, or you would want to increase the dose of co-formulation, but again, if you start increasing, you will end up in fasting hypoglycemia. So here is where we will have to use other agents, probably oral agents, to support this to control glycemia. So this is one intrinsic problem with all co-formulations. That is why in certain cases it is better to split basal separately and bolus separately. So in an appropriate patient, definitely yes, once a day. And if appropriately uncontrolled, that is if the clinical scenario permits, we could use twice a day. But quite a lot of patients might require twice a day.
So if there are no more questions, here it is time to say goodbye to this interesting session about a new molecule. Over to Dr. Ramakrishnan.
Thank you, Dr. Karthik and Dr. Ramakrishnan, which is a very educative session on insulin, particularly the newer insulins and its importance in preventing the dreaded complication for most of our patients, that's hypoglycemia. Thank you, both of you.